Hi, everyone, and welcome to the Yost Willems Early Career Investigator Competition. Let's see, I'm going to try to screen share here. Can you, right, let's try again here. Oh boy, I'm not able to screen share. All right, well, let's just go ahead and go here. I want to welcome everybody to our session. This is the Yost Willems Early Career Investigator Competition. My name is Michelle Pelter, and my co-chair, Mary Carey, and I welcome you to the session. This session is in tribute to Yost Willems, who was a cardiologist and scientist who earned both an MD and a PhD. His major interests were in computer analysis of the ECG. His major contributions were leading the common standards for quantitative electrocardiography, which was a very large European project started in 1978. This effort ended in a publication in the New England Journal of Medicine, and this effort reduced the wide variation in ECG waveform measurements and established the determination of the onset and offset of the P, QRS, and T waves. Professor Willems' contributions to the field of computerized ECG were recognized by ISKI in 1995, who renamed this competition to the Yost Willems Young Investigator Competition, which was later updated to the title of the Yost Willems Early Career Investigator Competition. This competition is open to current students in an academic degree program or individuals who have earned a terminal academic degree within the past 4 years. Previous competition winners may not resubmit. Non-winning finalists from a previous year may resubmit once. Each finalist receives travel reimbursement, waived conference fees, and a 1-year membership to ISKI, including a subscription to the Journal of Electrocardiology. Individuals who submitted an abstract which was deemed acceptable but were not selected as a finalist are invited to present a poster or talk and receive a 50% reduction in conference fees if they do so. The format will be a 15-minute presentation, and adherence to this 15-minute time period for the finalist is very important because it is part of the scoring criteria. Thereafter, we will have a 15-minute question and answer period. We emphasize questions rather than comments to our finalists, and co-authors on any of the abstracts are asked to refrain from asking questions, but everyone else is encouraged to do so. Judges for the competition are among us, and only the chairs of this session know who those judges are. And the winner will be announced tomorrow in our closing ceremony. And with that, I'm going to turn it over to our first finalist, Zineb Bouzid.
Hi. I'm going to share my screen. My presentation.
You get it?
I'm really sorry.
No problem. Take your time.
I kind of like have permission denied for some reason. I have permission denied. You're seeing my document earlier, right?
I did see your PowerPoint earlier. Do you have it?
I got it. Thank you. Yeah, the permission was denied. I'm sorry.
Very good. Be sure to put it in the presentation mode.
Please confirm that you see my presentation.
That's perfect. Go right ahead.
Great. Thank you very much. I'm really sorry for this inconvenience. Hi, everyone. My name is Zainab Bouzid. I'm a PhD student at the University of Pittsburgh, Swanson School of Engineering, and I'll be presenting my most recent work in a talk entitled Novel Approaches to ECG Feature Selection for Dimensionality Detection to Optimize Culprit Lesion Detection using only the pre-hospital 10-second 12-lead ECG. In terms of disclosures, there is no conflict of interest, nor financial or any relationship with industry to disclose. The study was sponsored by a grant from the National Heart, Lung, and Blood Institute, and this is the U.S. patent number invented by Avlady, Sadich, and Holloway, with which the algorithms developed in the study are associated. So I will start by talking about the clinical problem. So the standard 12-lead ECG remains the mainstay for evaluating patients with suspected acute coronary syndrome, or ACS, during first medical contact. It has the disadvantage of having a unique 3D coverage of the heart over frontal and horizontal planes. Detecting the presence and severity of coronary occlusion, i.e. culprit lesions, can guide timely therapeutic interventions and significantly improve patient outcomes. We're going to look at the three main coronary arteries or branches in the heart, which are abbreviated LAD, LCX, and RCA, standing respectively for left anterior descending, left circumflex, and right coronary artery. Well, this presentation will be referring to the culprit lesion affecting those arteries with the acronyms of the artery. So, however, current automated algorithms are suboptimal in detecting and localizing culprit lesions in ST elevation ACS. Here we can see a few algorithms performance taken from the reference below, which are not very sensitive to this outcome and present great variability. Furthermore, we currently have no tools to detect the presence of actionable culprit lesions in those with non-ST elevation ACS. So acute ischemia affects the configuration of the QRS complexes, the ST segments, and the T waves, yet most of these algorithms are primarily based on ST segment deviation alone, which constitutes a missed opportunity and explains the suboptimal performance seen in many automated algorithms. And markers of electrical dispersion incorporates much more information in the ECG than that provided by measuring elevation of the ST segment, and thus herald the emergence of more powerful and robust methods of assessing ECG morphology than can be provided by classical interval and interlude measurements. So we have previously demonstrated that markers of ventricular and depolarization and repolarization dispersion on the standard 10-lead ECG, 12-lead ECG over other than ST segments can improve the classification performance of ACS during first medical contact. Those are two references from recent papers we published that emphasize this point and highlight the importance of machine learning methods to reach these conclusions. So in the present work, we sought to explore whether novel features of ventricular depolarization and repolarization dispersion on the standard 12-lead ECG can optimize the classification performance of the presence of culprit lesions in patients evaluated with suspected ACS. So this is a prospective observational cohort study. We recruited patients with chest pain transported by emergency medical services to one of 3 tertiary care hospitals in the United States between the years of 2013 and 2016. And then clinical outcomes are adjudicated up to 30 days after the admission. So these outcomes are the following. We will be having 4 outcomes. So 3 culprit lesion types, LCX, LAD, and RCA, which are binary variables where the presence of the culprit lesion is indicated by 1 and its absence is indicated by 0, and also another variable which indicates the presence of any culprit, which is logic or between the 3 different individual culprit lesions. The outcomes are adjudicated by 2 independent reviewers, and the models we developed consider one variable at a time, so this is not a multi-class classification. So these are the ECG data characteristics, and it's important to note that these with excessive noise or artifacts were substituted by the next serial ECG obtained during emergency evaluation, and after the features are harvested from the ECG, they were normalized with an L2 norm, and missing values are placed by the mean over the corresponding variable. So what are these features actually? So a total of 557 global and lead-specific features of PQRST waveform were harvested from the representative average beats, subintervals, amplitudes, areas, angles, axes, loops, and eigenvalues using previously validated manufacturer-specific software. However, the complexity and efficiency of certain features may result in the decrease of accuracy of ML algorithm and the occurrence of overfitting. This is what we refer to as the curse of dimensionality. In the absence of dimensionality reduction as a pre-processing step, the number of data points needed to obtain a good accuracy should be significantly high to account for the sparsity of the data. Considering a potential exponential growth of the patient's number as a function of the features number, it is reasonable to decrease the number of features to the minimum that would keep all information conferred by the ECG, while avoiding all these problems of overfitting and the curse of dimensionality in general. So we used some feature selection algorithms. So it was basically a data-driven feature selection. And we investigated some feature selection approaches driven by data. So we used a combination of feature subsets obtained by machine learning algorithms for dimensionality reduction. And here we opted for feature selection as opposed to feature extraction algorithms for interpretability reasons, because feature extraction algorithms may result in a set of new features that are the combinations of the original ones, so it would be harder to trace back the contribution of the initial feature set. So the task we will be modeling for is the classification of the aforementioned outcome data, one variable at a time. For that, we are using 10-fold cross-validation with a stratified version, so that each split has the same, split or fold, has the same classes distribution as the global set, which is an unbalanced data set. We are using random forest because classifier because it gives reliable results for unbalanced and nonlinear data, and it also is robust to outliers. For feature selection, we use least absolute shrinkage and selection operator, or lasso, and recursive feature elimination while tuning for their typing parameters as shown here on the slide. So the data for 2,400 patients was used, and here are their characteristics in terms of demographics and past medical history. Among our sample of 2,400 patients, 84% had non-ACS etiology and 16% had confirmed ACS. Among the latter, 20% had no culprit lesions, around 40% with single vessel disease, and around 40% with multi-vessel disease, which reflects the complexity of these patients. So for modeling purposes, we can see here the prevalence of each culprit lesion, as well as the prevalence of 0, 1, or multiple vessel disease for the any culprit outcome. Here we have 7.2% of LAD culprit, 4.8% of LCX culprit, and 5.7% of RCA culprit. This proves that our dataset suffers from severe imbalance of the binary outcomes. So for the LAB model, we ended up with 35 features from the initial set of 557 features. And using these, we had an area under the RC curve of the 10-fold cross-validation of 0.82 plus or minus 0.05. And using an RC optimized cutoff value here is our confusion matrix. So our sensitivity is of 65.7% and specificity is of 82%. Positive predictive value equals 21.98%, and finally negative predictive value is equal to 96.87%. And to the right, we see 5 features with their relative contribution to the classification performance. We did the same procedure for LCX. The feature selection process resulted in 29 features, using which we obtained an area under the ROC curve equal to 0.84 plus or minus 0.04. The sensitivity and the specificity were equal to 72.81% and 77.38% respectively. Similarly, to the right, we see the 29 features with their relative contribution to classification performance. Similarly, for RCA, the feature selection process resulted in 51 features, using which we obtained an area under the ROC curve equal to 0.85, plus or minus 0.08. Again, to the right, we see the their relative contribution to the classification performance. We notice here that there is a better mean area under the curve of the ROC over the 10-folds compared to the previous culprits, but it's also important to note that the variability increased. But we can find the feature precision to generate a prediction for any culprit. Some features were redundant, that's why merging them resulted in 90 features instead of the sum of the number of elements of the previous feature subsets. We obtained an AUC curve equal to 0.85 plus or minus 0.04, which is very interesting because we have a high AUC and also a small variance over the 10 folds. And to the right, we see these 90 features with their relative contribution. After applying the adequate threshold, we actually used the geometric mean method, which is effective in the case of imbalanced classification. We obtained this confusion matrix resulting in sensitivity of 71.71%, specificity of 84.73%, positive predictive value of 36.13%, and a negative predictive value of 96.13%. Now we want to compare our performance to a reference standard, which is the Philips commercial software. Although we can see great improvement in sensitivity, the specificity of the commercial software is higher. And for comparison, we decided to compute the NRI between both methods. So NRI stands for Net Reclassification Improvement Index. It simply means if you have a new test to replace an old test, how good or bad on average does the new test perform when you want to override the predictions of the old test? We want to assess this. So our NRI was 23.6%, which means among 2,400 patients in our study, 23.6% of all patients treated with a pre-hospital ECG can be reclassified correctly using our ML algorithm, as compared to the automated software. This is pretty impressive NRI score. Think about the 10 million chest pain patients evaluated annually in the US and having a new test that can reclassify correctly 23% of those, which can affect the clinical history of around 2 billion people. Now I want to move on to presenting a couple of ECG examples to better understand the clinical implications of these results. So this is the ECG of a 60-year-old male patient with 80% occlusion in one of LAD branches, and the patient had a stent placed in that artery. The automated algorithm detected a Q wave in V1, V2, and V2, and suggested potential infarct, but remained inconclusive. Our model reclassified this patient correctly for LAD occlusion. A more interesting case is this 58-year-old male patient with 50% occlusion in main LAD and 90% occlusion in main LCX. The automated algorithm detected a right bundle branch block and did not interpret for infection. Our model reclassified this patient correctly for culprit lesion. So while maintaining specificity higher than 85%, our machine learning based model improved sensitivity by 35%, with net reclassification improvement index of 23.6%. Features contributing to this gain in diagnostic accuracy were metrics of ST80, T-peak T-end, spatial angle between QRS and T vectors, PCA ratios of STT waveform, T-axis, and QRS waveform characteristics. Thus, we can conclude that metrics of ventricular electrical dispersion on the 12-lead ECG can augment the prediction of coronary lesions on standard 12-lead ECG during first medical contact, which has important clinical implications. With that, I finished my presentation. Thank you very much for your attention, and I'll be happy to answer any of your questions. Can you hear me?
I can. Thank you so much.
Thank you very much.
Thank you. I can't get my camera back on, but I'm going to pose some questions for you from the audience here. Okay, so the first question, Dr. Bouzid, is what was the reason to use the 12 norm for normalization?
It's L2 norm, yeah. Basically, for machine learning algorithms, it gives better performance if all the variables are normalized. So, for example, there aren't a variable that has ranges from 0 to 1,000, and the other one that has a range from like 0 to 0.5. So we normalize all variables with the L2 norm to be between similar ranges, just for have a uniform.
Okay. Next question. What was the distribution between training, test, and validation set if different sets were used?
Okay, so it's 10-fold cross-validation. So we have let's imagine this full data set. We divide it into 10, and then at each time we train on 9 folds and then leave one out for validation. And then we move forward. So we do the process 10 times, basically, where each fold is used at least once for validation. And then we average over all the results. That's what K-fold, whatever K is, cross-validation stands for. So we did not have an external testing set for those preliminary results or this preliminary study, but we are working on further more cohorts in order to do the testing on them. Basically, we assume that we're taking cohorts that have similar characteristics, so we did not want to just leave some number of patients out of them so that we do the testing right. We just want some completely independent testing set we're working on, or the members are working on.
Okay, very good. Next question. Can you clarify how you perform the feature selection when you're doing 10-fold cross-validation? In other words, which fold do you actually take the selection features from?
It's basically averaged over the different folds. So there are basically different features from different folds, and it's kind of like the embedded function kind of sees most probably the most recurring ones, my understanding.
Okay. How was the NRI calculated?
There is a formula for the calculation of the NRI. So basically, we try to find. It's better explained if I have this in front of me for the numbers. So if
You can screen share. Do you want to screen share? Would that help you?
I don't have the formulas in front of me, but can I use an external resource to screen share it?
Sure.
I just want to, yeah, I'll just share the screen first. It's basically like I wanted to find the fastest. It's like just a Wikipedia element, but it's very expressive because we have here the method of calculating the NRI. Let's suppose that abnormal stands for half culprit and normal means no culprit. We have the test one, which is the commercial algorithm's prediction, and the test two, which is our prediction. We basically are comparing two vectors, two binary vectors. So we see what's the number of abnormal ECGs that are shared, what is the number of like normal ECGs that are common, and then what are the numbers of abnormal ECGs that are classified by our algorithms as normal, for example. And it's like a crossing of all these numbers, right? And all of that is keeping into account the actual outcomes, which are adjudicated by the clinicians. So here, the gray ones are the actual outcomes that are events, which means culprit, for example. And here, they are classified as culprit by the test one and the test two. There is a very clear formula of how to compute all of this, basically. Oh yeah.
Very good.
Is this way for me to explain it?
Dr. Bouzid, can you please describe your role in the study that you just presented?
So basically what I did is I took over starting from the data management, which means pre-processing, and then also the modeling of the different machine learning algorithms. Of course, the conceptualization of this work is done with the guidance of my clinical teammates. So yeah, basically I developed all of the algorithms, the technical aspects of the project.
Great. I think we have time for one more question here. Maybe we can get into why is it important to identify the culprit artery, as the treatment is basically the same whatever artery is or may be involved? Is it not better to identify area at risk, understanding that the two are not unrelated?
So I'll try to answer the question. I'm not the clinician in the team. We have a multidisciplinary team, but I'll try to convey my understanding of this matter. So, to my understanding, we are trying to localize basically where this the occlusion is happening. So it's not necessarily just the artery itself. We want to see we are having, for example, a patient. It was predicted to have. The prediction was saying that we have an ACS, and we want to understand in specific which region of the heart is affected.
Very good. Dr. Bouzid, I think that is our time limit. I'm going to sign off and invite everybody to come to the next early career investigator competition. Thank you very much.
Thank you very much. That was great.